But I got jaded about the whole idea of special people getting access to palliative care services when there were thousands out there that weren't getting access to that. I got very interested in chronic life-limiting illness, and particularly in the part of the disease trajectory that isn't really addressed yet. And that's where, from the time of life-limiting diagnosis in the last 3 to 5 years of life, we're still applying an acute care, disease-focused model when we should be more and more, and many GPs do this already, applying a supportive care model alongside the disease-focused model. We've got a wonderful Department of Health and Human Services in Tasmania that likes to look after their specialists and their workers. Said, go and find a model that works. And I did. I went all over the place searching and saw Gold Standard Framework, which I'm sure some of you would have heard about, and spent time at St Christopher's Hospice as well, where their core business now is not just hospice care for that lucky few that can get in there, those often young people with young families with very complex needs, but actually looking at the hundreds and hundreds and hundreds of people out in the community with chronic advanced organ failure, frail age with multiple comorbidities and dementia. So I was inspired, if they could do it, why couldn't we? So with Kerry Thomas, the professor who leads Gold Standard in UK, we started to adapt and implement that in 5 nursing homes in the northwest. About 400 to 500 residents in those nursing homes, and working with the aged care providers there. And the first thing we did was look at, why use Gold Standard? We look at trying to change the culture, because I've been involved, as have you, with training and education for years and years and years and years and years and years, and it doesn't change the culture. And you can keep on training and giving information, but nothing changes unless something changes inside that practitioner about their attitude to supportive care and their attitude to supportive and palliative care. So we thought, well, I've worked so long with the GPs, I'm going to start with the nurses and the carers, and that's where Gold Standard Framework is so, so valuable. It works at putting person-centred care right at the centre of care, not doctor-centred care, not nurse-centred care, not facility-centred care, not acute system care. It's actually putting the person there. When we do that, no one argues. People stop blaming each other. Nurses stop blaming doctors. GPs stop blaming poor assessments from nurses.
The eHealth system that Robyn Brogan described that they've set up in Tasmania, it was such a wonderful system to hear about. It was truly patient-centred care, based in residential aged care facilities, based in a regional area that covers a broad spectrum of people. And what they provide there is a mechanism for people's beliefs and goals to be incorporated into their care. They really listen to people, they try to understand what people want, and then they develop a goal of care working around that. As well, once they document it, they then attach it to an eHealth record.
When you put person-centred care at the centre of your care, we start with dignity and exploration, which the carer's involved with. We look at freedom and autonomy. How important is that to the person? How important is it to that person who has motor neuron disease, that's been forced to have pureed food in the last weeks and months of their life, who doesn't want it and screams and has panics, is labelled as behavioural and given psychotropic medication, when all they want is the freedom to have what they want. So, okay, freedom is important to this person. Pleasure's important, comfort's important, and safety and security not so important to that person. So if we identify what the core values are for these people, we can then start aligning the care with this person's values so we can promote their dignity rather than undermine their dignity. That we look at preferences for information. Does the person want information about their illness? And all the stuff that Joey Clayton's done, which I'm sure you've seen, about how to sensitively give information to that person about their illness. Do they want to know? If they don't want to know, who do they want to know about it? About their diagnosis, about what might happen? Do they want to know about that? Do they even want to know that they may be dying? Then the next thing is we find out their preference for involvement in decision making about their day-to-day care, like the food, all sorts of things, the time you get up. Once we've got engagement with them and know what their preferences are for information, involvement, decision making, we also then start working out with them where is their preferred place of care. And in nursing homes, after they've settled in and they're starting to trust the staff, they often want to stay there rather than go to hospital. And by and large, there's very few people that actually want to be readmitted to hospital again. And you are aware, I'm sure, that it's, for new people admitted into an aged care facility, there's about a 60% chance of you dying in that first year. So you really are on a palliative pathway, aren't you, at that time? Starting from that person-centred care, we then look at their advanced care planning only at that stage. And when I say we, I'm not talking about me. We in this situation are the carers, the enrolled nurses, the RNs, who have an ongoing, close, caring relationship that evolves over time and collects this information and puts it in a really secure place that's available to other carers and other staff to know what is it about this person that we could really promote their dignity and their well-being. And once we've got that stuff, we then do the advanced care directives using enduring guardian form and statement of wishes and their preferred special requests and all sorts of things, and make sure that that's in a secure place, in the same place that people can find out. And then after that, we start then looking with the primary health team, the GP, the other allied health people, the speech therapists, the pharmacists, get them involved in, okay, what are our goals of care with this person? And for that decision-making, we use the work of Joanne Lynn, the surprise question, and the Scottish people, the prognostic indicators of GSF, that you've probably heard of the surprise question, where you sit down with carers, RNs, GPs, the team there, and say, well, will we be surprised if Mrs. Smith died in the next 12 months? No. Right. Will we be surprised if she died in the next 6 weeks or so? Yes. Well then, okay, she's got months left, so let's do some planning for the next phase, find out what she wants, and get her comfortable now. But if Mrs. Smith, your response to her was, no, we wouldn't be surprised if she dies in the next 6 weeks. She's got chronic obstructive airways disease and a bit of heart failure, and she keeps having these acute episodes where she comes very close to death. No, she always recovers, but we wouldn't be surprised if in the next one she died. So let's plan ahead. What would we do then for the next 6 weeks if she had another chest infection or a fall and a fracture? What would we do if she suddenly entered into the dying phase, last hours, days? Would she go to hospital? Well, what are her wishes? Does she want to be involved in this? Her carer, her enduring guardian, shall we involve them? And then the team comes together with the family and the person to the degree that the person wants to be involved and starts to do clinical action plans that are actually aligned with that person's dignity and their preferences and their wishes and their advanced directives. And before we do that, we decide as a team, the GP and the nurses, is this person on a disease-focused pathway? Or have they become more and more like, should we be putting a greater emphasis on supportive care, which is what every GP does, which is person-centred care, looking at the wider needs of the person rather than just the organ or the function or the numbers? And when should we start to move towards a supportive and palliative pathway where we're not trying to prolong life anymore, but really focusing on the wider needs, including spiritual and cultural aspects of that person, the family's needs, not just the person's needs, and really meticulous symptom control. So we have a culture then that is ready to do that change because the nurses and the carers are an aligned team and they support the GP. So we plan for the expected deteriorations, the chest infections, the deliriums, the falls, the fractures, and we also plan for the unexpected deteriorations. Who knows what that might be, but if we know the person wants to stay in the nursing home, they want good symptom control, and we've got clinical action plans for whatever symptom is coming because we're using a palliative and supportive approach at this stage, then the staff have got a relaxed way of dealing with even unexpected deteriorations. They no longer become a crisis. I could talk about so much, but let me talk a little bit about the eHealth part of this. We were lucky enough to be selected as a Wave 2 site for the personally controlled eHealth record, the PCHR. And that meant we had access to this amazing team called Alcidian, Professor Malcolm Pradhan, who's a doctor, but also health informatics specialist, that not only has determined with his team how to actually attach the Advanced Care Directive or Enduring Guardian or Statement of Wishes to a PCHR. If that doesn't come on the 1st of July, we've still got a portal we can use that means a cloud up there, a GP assist after hours, ambulance, ED, a GP at home can access and see what that Advanced Care Directive is. So that's the first thing. The next thing is the 4C portal has actually allowed us to put this whole program of advanced care planning, looking at the dignity, the preferences, and has developed pathways with clinical action plans for the last 6 weeks of life and for the last hours and days of life. So it means a GP, once it's up and running, which is supposed to be the 1st of July, can actually plan ahead when someone's got months, can plan ahead for the likely deteriorations for that disease trajectory for that person. And say, okay, I want plans for chest infection. This person doesn't want antibiotics, but I'm going to go and talk to them. If there's a lot of sputum, maybe they will take some oral antibiotics for a while, but no, they don't want it, okay, definitely not on. But let's treat the dyspnea and the respiratory panic and the delirium that might happen with that chest infection. What do we use? Oh, there's drugs that come up. And they've been sort of individualised to the doctor's favourite ones. So if they like morphine, that's what comes up, hydromorphone. If they like haloperidol, risperidone, that's what comes up. With really good safe doses and, that you can start with. I mean, primary palliative care, not specialist complex care. Primary palliative care for the usual symptoms that happen in the last 6 weeks of life. So there's all sorts of other capacity there too in terms of screening and letting GPs know. How am I going for time? 5 minutes. Letting GPs know that there's a flag, that someone's got a delirium, that we need to get an advanced care plan happening for this. There's no clinical action plans for their dying phase and they're deteriorating.
I think that it's part of a revolution. We've got to go from the little computer systems that we have in doctors' surgeries that are very confined to a box in a room, and we've got to think about computer systems that are cloud-based and that we can access wherever we are through whatever computer we're in, and we can each contribute to, if we're going to do teamwork, we can't work from a single site computer. We have to get into this web-based technology that's becoming so common these days. And I think that's the future. And I think in rural and remote areas, you can see an application, brilliantly. You can also see how people, specialists and others in other areas could contribute to what you're doing by being able to actually log in as well. So I think it is, add to that the telehealth opportunity that's really coming up, and then you've got potential that gets larger and larger.
We think that eHealth can help to join up, solder up parts of the health system where people fall through the cracks. The personally controlled electronic health record means that patients will be able to assemble their own records in one place and share them with their next provider. That helps to put patients in a lead role, not just a passive role about their own care. These are journeys, not destinations, though. It's going to take quite a while to sort out some of the jumble of financing and some of the jumble of how eHealth will finally land in terms of providing better decision-making for patients and doctors and nurses, and assemble records in one place so that anybody can find out what's happening and where the patient's up to, including accessing their test results and other things that are happening to them.
The system that they're using in Tasmania is based on the gold standards framework, which is developed in the United Kingdom. And given that it works well everywhere in the United Kingdom, whether it's a rural or a metro area, it should easily be transferable from northwest Tasmania out to the rest of Australia.